is sharing experience from a nationwide prevalence study.
Honorable Chair, learned audience, Assalamu alaikum. No prevalence data available in our country. How many of you have written this line in your thesis? I have written it in several of my papers, but it is no more true for diabetes in young. Data is available. Recently, I had the opportunity to be the part of a nationwide prevalence study through which we evaluated the community prevalence of youth-onset diabetes. In my presentation today, I will discuss about how we prepared for the study, how we actually conducted the study, and what was the result of the study. So let's start with the preparation for the study. The preparation started way back when we formed a group called Study on Diabetes in Young, SODI, in the Department of Endocrinology, BSMMU. The group conducted quite a few hospital-based studies on pathophysiology and genetic aspects of youth-onset diabetes mellitus. However, the group felt that community-based studies are very much needed to clearly understand the nature of our ever-increasing young diabetic population. So, we plan to carry out a study on prevalence and risk factors of diabetes in young at the community level. We start building a team. We collaborated and encompassed faculties and experts from other departments and other institutions. We had Professor S.M. Arafat sir with us, Professor Indrajit Prasad sir with us, Dr. M.D. Khalikuজ্জামান sir from Public Health BSMMU with us. We started to accumulate the equipments that will be needed for field level study. Side by side, we were preparing a study protocol. Let's see what was in our protocol. The title of the study was Prevalence and Risk Factors of Youth-onset Diabetes in Bangladesh, a nationwide survey. And the objectives were to ascertain the glycemic status of young people by oral glucose tolerance test and thereby to estimate the prevalence of youth-onset diabetes. We also wanted to identify the socio-demographic and clinical risk factors associated with youth-onset diabetes mellitus. This was a cross-sectional study which encompassed people aging 10 to 34 years, living at least 6 months at the study sites. Now, what were the study sites? There was one urban and one rural site from each division of Bangladesh. We calculated a sample size of around 150 in each study site. We had total 16 study sites, so the calculated sample size was about 2,400. How did we recruit the study participants? From each administrative division of Bangladesh by multi-stage random sampling, we chose one ward per division and one village per division. So, we had 8 urban wards and 8 rural villages. We enlisted the eligible participants of these wards and villages, and then we randomly selected for screening OGTT 200 from each ward, 200 from each village. So the study invited 1,600 participants from urban sites and 1,600 participants from rural sites. Ultimately, in urban site, 1,099 attended our OGTT screening program, and in the rural side, 1,241 attended the OGTT screening program, and the total participant was 2,340. What was the study procedure? As I said, Participants were requested to attend a particular site at a particular date in fasting state after overnight fast. Then fasting venous blood sample was collected after obtaining the informed written consent. Then oral glucose load was administered and the patient was advised to wait for 2 hours before the collection of second venous blood. During this waiting period, we collected the socio-demographic and clinical data. The glucose was assayed by a semi-automatic portable biochemical analyzer on the same day of sample collection at the study site. A serum sample was brought to the department for further biochemical analysis. This was the list of variables which was evaluated in the study. Now the protocol is ready. Now the question is about funding. We are very happy that Non-Communicable Disease Control Program of DGHS came forward to fund our study. We also get support from different pharmaceuticals, especially for accommodation and transport of the study team. We obtained ethical clearance from IRB of BSMMU. Now it is time to conduction of the study. These are the study sites which we traveled over the last 6 months, and just in the first week of this month we have visited to our last site in the Chittagong. Before going for data collection, we had a pre-visit to the study site in every divisions. In the pre-visit, we trained the field workers. In each site, we recruited a different set of local field workers. We trained them how to go to door and make a list of eligible participants. Along with, we also try to form a network with local healthcare providers and local leaders, especially the local endocrinologists tremendously helped the study, and I am more to say, without their help, it was not possible to carry out the study. The local authorities also helped us a lot. Even in Borishal, a road was repaired by the local authorities to facilitate our visit. Selecting a sample collection venue was also an agenda of pre-visit. We selected schools, colleges, madrasas or hospitals in the study site for our sample collection venue. Well, pre-visit is now done. Then our work is to prepare for sample and data collection visit. For this, we have to maintain continuous communication with the field workers so that they could recruit eligible participants. And in our department, we conducted multiple sessions to prepare our investigator team to ensure uniform and proper data collection. We had to mark thousands of sample collection tube and Eppendorf tube before going to the visit, and we have to pack all the instruments to bring them to the study site. Our day started very early at the day of sample collection. Often I texted the study group members, breakfast is at 6 a.m. and start for sample collection venue at 6:15 a.m. However, everybody happily accepted, and we were very happy to work. Some of us received the participants and guided them to one of the 4 booths for ODTT and data collection. Some were busy with collection of blood sample, some were occupied in data collection, and some busy in anthropometric measurements, glucose preparation, and in tidying up the samples. Everyone had their predetermined job to do at the day of the data collection. We could not ignore the demand of the local people and provided limited consultancy and measure blood glucose by glucometer in those who were not eligible for the study. After collection, we set up a mini lab at the sample collection site. We had 2 persons with us who are expert in lab works, and others also helped them a lot to separate the serum and to measure plasma glucose within the study site. We were very serious about waste disposal. We ensured their proper disposal by incineration in every site. After the day of extensive work, we got some free time. had some fun, roamed around, and made new friends. As we can see, our mentor has found a pretty girlfriend at last. Along with the data collection, we organize symposia and awareness programs for the physicians in almost every district where we visit. Now, the question of results. The total participants were 2,340, but we had to exclude 40 because in 5 tests was not done in fasting state. Pregnancy was there in 16 and some were overaged. So we included 2,300 persons in analysis. The median age was 19 years with an interquartile range 15 to 26. We divide our study participants in 2 groups. Adolescents aging 10 to 18, their percentage was 48.6, and young adults aging 19 to 34, their percentage was 51.4%. Among our participants, 51% were female, 53% resides in the rural area, 24% had family history of diabetes mellitus, and 18% were obese. Now the question is, what was the prevalence of diabetes and pre-diabetes in young in these study participants? We observed a prevalence of 4.5% of diabetes and more higher pre-diabetes, 18.4%. However, if we divide our population into adolescents and young adults, we observe different prevalence. In adolescents, diabetes was only 1.3% with pre-diabetes 17.6%, but in young adults, diabetes prevalence was much higher, 7.4%, with modest elevation of pre-diabetes prevalence also, 19.2%. We came to know from the previous study that in young onset type 2 diabetes mellitus, there is a female preponderance. What did we observe in our study? We observed in male, prevalence of diabetes is 3.8% and pre-diabetes 13.6%, and in female, prevalence was 5.1% with 23.3% pre-diabetes. So the world literature is also reflected in our study. If we divide our study participant in urban group and rural group, we observed higher prevalence of diabetes in the urban area than the rural area. Now, what was the prevalence of diabetes in young according to the divisions? Interestingly, Dhaka division had much higher prevalence of diabetes in comparison to other, ranging to 11.4%. Followed by Khulna and Borishal around 6%, and Mymensingh and Rangpur had the lowest prevalence of diabetes in our study, around 2%. If we categorize our study participants according to the BMI, then how was the prevalence? We can see with the increase of BMI, the prevalence of diabetes and pre-diabetes progressively rising. In underweight, only 2.5% were found diabetes, and in obese, the prevalence of diabetes was 10.4% and pre-diabetes 26.5%. Is it related to central obesity and acanthosis nigricans? Yes. In participants with central obesity, the prevalence of both pre-diabetes and diabetes was naturally very higher. And in participants with acanthosis nigricans also, the prevalence was higher. Is there association of diabetes in young with dyslipidemia and hypertension? We measured fasting plasma, fasting lipid profile and observed that in persons with dyslipidemia, there is much higher proportion of pre-diabetes and diabetes. And also in persons with raised blood pressure or hypertension, we observed higher prevalence of diabetes. Family history is very important because genetic component is regarded as very important part of pathophysiological process in diabetes in young, and we observed that in persons who had no family history of diabetes, then the prevalence of diabetes and pre-diabetes is lower. In persons with family history present had a prevalence of 7.4% and pre-diabetes 21.4%. Female participants with history of GDM and hirsutism also had much higher prevalence of diabetes. Also, the participant with history of GDM and hirsutism was much lower, and we could not draw any statistical inference. However, it reflects the three study group we are working together: study group on young diabetes, study group on GDM, and study group on PCO. We are all linked together. I have come to the end part of my presentation. Now the summary of the result. In short, the prevalence of diabetes mellitus in young of Bangladesh as observed under this study was 4.5% and the pre-diabetes 18.4%. Prevalence is higher in young adults in comparison to adolescents, in female in comparison to male, in urban area in comparison to rural area. And there was association with common risk factors like obesity, central obesity, acanthosis nigricans, hypertension, dyslipidemia, and family history of diabetes mellitus. We have some future plan. We want to analyze the biomarkers and genetics of stored samples from the community, which we have preserved in -70-degree freezer. We want to follow up this study cohort to see the change in glycemic status over time. And our dream is to set up a self-sustainable community screening and management program so that these people can arrange their own screening and management in by their own locality. In conclusion, there are challenges in community-based studies, and these are quite different than hospital-based studies. Dysglycemia among youth is not uncommon and often associated with other cardiometabolic risk factors. Our study group want to continue the endeavor and seeks collaboration all over the country. We are happy that our paper was sent to IDF and it is accepted for a short oral poster presentation. I would like to acknowledge my mentor, all the members of the study group, co-investigators of the community study, funding agency, endocrinologists and medical, non-medical personnel all over the country who helped in our study, organizer of the conference. So at last, I would say that we should focus more on community-based studies. We should not confine to do the research only in the hospital. Thank you very much for your patience hearing.